series. So it's our monthly event, and today we are very happy to have Dr. Jasmine Lim to share with us on polypharmacy. But before I invite, I share with everybody about Dr. Lim's bio. May I invite our CEO, Dr. Christina Tiong, to say a few words.
Hi, everyone. A very warm welcome and Happy New Year to all of you. I'm very thankful for Dr. Jasmine Lim's generosity to spend her time with us this afternoon. As you know, Home Nursing Foundation is the largest home healthcare charity in Singapore, and we are providing home-based medical, nursing, therapy, and home personal care to frail and vulnerable patients. Currently, we also run 2 senior care centers with community rehab and 1 active aging center in Buangkok to serve the needs of both the well and dependent seniors in the community, with the aim to improve their function, their overall health and well-being. Under the prolific leadership of Dr. Ng Wai Chong, we have started to organize a series of continuing professional education every month to raise our understanding and the practice of holistic, person-centered care to all our patients, including their caregivers and families, and empowering them to live joyfully in the community. Since 2022, we have completed a series of CME on end-of-life care, functional rehab, dementia, falls and osteoporosis, mental health, Parkinson's, wound management, and also caregiver support. And the last was social prescribing, and many of these sessions are recorded and available for your viewing on YouTube using the QR code that we will share with you shortly. This afternoon, we are eagerly looking forward to the sharing by Dr. Jasmine Lim, and she has very kindly agreed to spend her precious Saturday afternoon with us. So I will pass the time to Dr. Ng to introduce her. Thank you.
Thanks, Christina. So, how this talk came about was because I heard from a senior consultant geriatrician friend that she heard Dr. Jasmine Lim taught polypharmacy to the hospital teams, and she felt it was a very good lecture. So, and that's why I approached Dr. Jasmine Lim. So I had the honor of working with her a few years ago in Ng Teng Fong Hospital in a project in Bukit Batok. But just a very quick introduction. Dr. Lim is a consultant geriatrician in Ng Teng Fong Hospital. But before that, she had a first degree as a pharmacist from NUS and worked her way through medical schools and then postgraduate training, and now a specialist in geriatric medicine. So today she's going to share with us on tackling polypharmacy in the community. The target audience is really doctors working in the community. It could be the home care physicians of Home Nursing Foundation, but I'm sure all of you here, general practitioners, nurses and allied health professionals working in the intermediate and long-term care sectors, I'm sure you'll find her session useful. I can also see social workers in the midst. So welcome. And now I'd like to hand over to Dr. Lim to share with us on polypharmacy. Dr. Lim, please.
Okay, thanks very much, Dr. Christina and Dr. Ng for the introduction. I'm very happy to be here to share to you a very important topic, which is medication management. Actually, is something that we deal with in the medical profession, and it's something that's very important in the older adults. So a very happy 2024 to everyone. Without further ado, maybe I'll just carry on with this lecture. I'm just going to go into 2 quotes by Sir William Osler. I'm sure everybody knows him. He's the founder of bedside teaching, and he is the father of modern medicine. So even in the 1800s and 1900s, he came up with 2 very wise quotes. The first one of which is that the person who takes medicines must recover twice, once from the disease and once from the medicine. His other quote is also very wise. It's really that sometimes education may be the way to go instead of taking more medications. Fortunately, with more research coming on now, I'm not sure what he will say now with evidence-based medicine coming in, and more medications are being prescribed to patients with chronic diseases. But as I go through the slides, you'll probably understand what he meant during those years. So maybe I just quickly share about polypharmacy, and does it really matter how we define polypharmacy? So basically, a standardized international definition is really lacking. I think most people will understand that polypharmacy, there is a numerical value that's attached to it. A lot of studies looked at a numerical value of 5. So more than 5 is considered to, a patient has polypharmacy. But what in essence is clinical applicability, it's not very, very useful, because what it does not do is it fails to acknowledge medication appropriateness. So you can have a patient with 10 medications, but if it's clinically appropriate and the patient is taking it well, it may not unjustify its use. Okay, so but it's a very good value to understand, because if you see a patient with 5 or more medications, it tends to ring a few bells in your head, and you try and look at the list a bit more detailedly and understand whether is it really suitable for the patient that we are prescribing for. Descriptive is another way to look at it. Is it minor, major, or excessive? But again, it's not really very comprehensive in terms of how we want to look at polypharmacy. Then we look at another definition that is probably a bit more appropriate for us at this point in time. That would be appropriate versus inappropriate polypharmacy. So polypharmacy which has been shown to have more benefit than harm. Okay, so this gentleman is actually from Okinawa. So we all know that we have a huge, they have a huge population of patients that live independently till the 90s. So they are a very fortunate group of older adults where multimorbidity is kept at quite a low level. But in most of the other countries, we are in this clinical conundrum, because as we age, we are collecting lists of chronic diseases. We have diabetes, hypertension, stroke, cardiovascular disease. And what happens is that as more and more research are trying to slow down the progression of all these diseases, we come up with more and more medications. And this leads on to fragmentation of care, because a lot of our patients with specific organ diseases are sent to subspecialty care. And this will lead to then what we call the twin phase of polypharmacy, means the good and bad of polypharmacy. I'll explain this further on in the subsequent slides. Just a bit about the prevalence in the community. I think internationally, if you look at all the international papers, the prevalence of polypharmacy is really on an upward trend through the years. So you can see from 1990 to 2015, it's just going on an upward trend. If you look at the graph on the right, hyperpolypharmacy, which is a definition of more than 10 medications in the elderly, is also increasing exponentially. So if we looked at polypharmacy within the inpatient community as well as nursing home setting, there is a high prevalence of inappropriate prescribing. Some of the studies shows 1 in 5 prescriptions in community dwellers are actually inappropriate. There was this quite prominent inpatient local study from the team, I think in China, where they found that there was also similar findings of inappropriate prescribing. If we look at this local study on the prevalence in nursing homes, the prevalence is actually very, very high. So 70% of patients had inappropriate medication use. If you look at the table on the right, what are considered inappropriate medication use? A whole class of medications have been identified. You have, vitamins with no obvious benefit. It's just additional pill burden. You have psychotropics. You have cardiovascular medications which has been found to be inappropriate. So in essence, if I understand from Dr. Ng that there's quite a lot of our nursing home colleagues here, I think deprescribing in the nursing home is probably a very, very big initiative that can or should be undertaken in the nursing homes, because we do see quite a fair bit of inappropriate medication use when they come to us. So at the end of life, prevalence is also quite prominent. In this study, it shows that actually very few patients have less than 5 medications, even at the end of life. So it's a very, very common problem, unfortunately. So what's the problem with polypharmacy? So as I was saying, there is a this twin concept in polypharmacy. There is a bad twin and a good twin. Sorry, I apologize for the background noise. My kids are at home. Okay, so basically the problems with the pearls of polypharmacy is that there's a lot of drug interactions and drug disease interactions if you prescribe more and more medications for the patient. So when I talk about drug disease interactions, it's really giving, for example, a very common example is giving anticholinergics to a patient with dementia or delirium. So that's going to cause more problems. It's going to lead to problems with compliance, with nutrition, weight loss. It can lead to more geriatric syndromes like falls, delirium, hospitalizations, institution, nursing home admissions, and mortality. So if you look at the table on the right, it sort of explains the pharmacokinetics of why we need to be very careful with giving medications in the older adults. If you look at the older adult's body constitution, it's really quite different from the younger adult. So serum albumin is a bit lower. So when you talk about drugs that are binding to proteins, distribution is a bit different. We talk about body fat. The distribution of body fat is higher in the older adults. So you have lipophilic drugs that are concentrated in body fat. So they get eliminated a bit slower. You get reduction in kidney function, reduction in hepatic blood flow, so clearance tends to be a bit slower. So the concept of starting low and titrating slowly actually applies to prescribing in the older adults. Yeah. So polypharmacy in essence, I put this picture here, it's actually the elephant in the room when we talk about geriatric syndromes. Okay, I came up with this strategy of how we want to approach polypharmacy. So we've talked about the prevalence, we talk about its definition, and we talk about the problems associated with polypharmacy. And now, so how do we want to start prescribing and ensuring that medication management in the older adults is optimal. So this is how I usually approach polypharmacy. Number one, frailty. So we have a broad view approach to assessing the patient. Is this patient robust, or is this patient frail, or is this patient very frail, or is this patient at the end of life? So what we're looking at is how complex is the care of this patient in terms of multimorbidity management. Then we move on to looking at medication reconciliation. I'll go more into each subset a bit later, but essentially, this is a very big part of the 4 steps. The third step is actually appropriate and conscious prescribing. Okay, so when we talk about conscious prescribing, we are talking about not adding to the risk of medications, the medication risk to a patient. Okay, and the last one is deprescribing. So removing medications with no clear indications of benefit. Yeah. Okay, so the first one is on frailty and complexity of care assessment. So this chart was pulled out from the NICE guidelines. It looked at how we want to really approach patients, because there's just a whole group of very heterogeneous older adults. How do we want to concentrate our resources such that we focus more on patients who are very vulnerable? So if you look at this diagram, if you go up the slope of this red arrow, as you go further down the axis, patients with multiple conditions, complex interactions, multiple fragmentation of care, very complex biopsychosocial kind of a dynamics, you actually need a more tailored approach to medication management. I thought this concept is actually very interesting. There is a bidirectional relationship to most of our geriatric syndromes as well as frailty. What we do in terms of polypharmacy affects frailty, and frailty in itself encompasses a lot of the polypharmacy that we see. So essentially, inappropriate prescribing in polypharmacy leads to what I've mentioned before, which are all the perils of polypharmacy. And this essentially leads to poor outcomes and worsening frailty. So if you're looking at a concept of trying to target frailty, or rather we are looking at services to halt frailty in the community, we are really looking at a big part of trying to tackle polypharmacy. So I like to think about, so I like this concept about older adults who are very vulnerable. They're like walking on a tightrope. So if you can imagine, you know, just a gust of wind can actually tip you over from the tightrope. And this population of patients, this very frail, vulnerable adults or patients are walking on a tightrope every time they come through our care. So as well as, I mean, not to mention even minor illnesses that can tip them over. So if you look at, I think this chart is very, very, it's been flashed many times if you attend many geriatric conferences. A simple UTI can, you know, tip them from independent to dependence. And they take a longer time to get back to where they are before. And this is what we call unstable instability. They're just very vulnerable in terms of their health status. Even as simple as starting a patient on amlodipine can cause postural hypertension, cause them to fall and cause them to tip over. So they're basically a very, very vulnerable bunch, and they're walking on a tightrope all the time. So this is a Asia Pacific clinical guidelines that has been drafted for frailty management, and I think a group of our local geriatricians have sat in this guideline, drafting of these guidelines. If you look at the recommendations, for strong recommendations, I mean, on top of identifying a tool, on top of getting them to exercise, number 3 is actually really addressing polypharmacy and trying deprescribing any inappropriate ones. Okay. When we talk about that, as I was mentioning about polypharmacy and the bidirectional relationship with frailty, this is, again, there is a bidirectional relationship with all our other syndromes. I like to think about syndromes as a tip of an iceberg. Okay, so if you have delirium, you know, it seemingly looks like just one diagnosis. You know, when you look at an iceberg, you don't know what's underneath the ocean. So it's the same as any of the syndromes. Underneath a syndrome is a whole load of other causes and etiologies that causes the syndrome, and hiding underneath this is actually a big part is polypharmacy. Yeah. Okay, so if we look at the next stage of how we want to look at polypharmacy management, is really medication reconciliation. I was thinking of what to put as a cover for my this second stage of management, and I thought this book was very in keeping to what I wanted to say. So if you're interested, you can get this book off the shelves, but I just thought that it was a very, very good book. If you don't mind, I just maybe just read through one of the synopsis of each. So there's an unspoken, so this was written by an oncologist, and I think she does a bit of primary care in the US. She wrote this book called Fragmented. So she said there's an unspoken assumption when we go and see a doctor. The doctor knows our medical story and is making decisions based on that story, but actually the reality usually falls short. So medical records vanish when we switch doctors. You know, critical details on treatment gets lost in medication charts. You know, that's like our NEHR, or you know, our primary care colleagues who do not have the privilege of looking at the NEHR list. The doctors we see change according to specialty. So this is all what she calls fragmentation, and it really is the central failure of healthcare today. So fragmentation is the reason why medication reconciliation is so important. So if you look at the AGS guidelines, I mean, AGS guidelines was found in this journal, but essentially what it says is that you should not prescribe a medication without conducting a drug regimen review. It's actually a crucial step in addressing polypharmacy. Okay, what it does when you do medication reconciliation is that it identifies 3 main things: whether the patient is compliant to it, whether you are prescribing appropriately and whether you are under prescribing. Okay. I thought, sorry if it's taking a bit, sorry, I think I need to move on a bit quicker. So this is, I just put on 2 cases here. They are actually, the first case is actually my clinic patient, which I have to confess, I didn't do a very good job with medication reconciliation, but it was a very, very big learning point for me. And I thought I'd share it here because it's, I think for, as I was teaching the medical students, I always try to give cases because it's easier to remember, especially when it comes to medication teaching. So basically, there's an 80-year-old Chinese female. She's seeing me for mild Alzheimer's dementia and cardiology for IHD. So what happens was that when she, over the course of 2022, her creatinine was stable. But suddenly at the end of 2022, her creatinine started rising. So cardiology increased her valsartan from 80 OM to 80 BD at the end of 2022 because the BP was very high in the cardiology clinic. So I saw her in early Feb 2023 and I increased her donepezil to 10 milligrams OM and I ordered an ultrasound kidneys for her worsening creatinine. So dementia daycare was very good. They were very, very alert with regards to the patient's condition in the daycare. And so they called me. They called my clinic and then I got back to them and they said that actually for the past 1 week, the patient was not eating and was very drowsy. So I was very concerned as to why over the past 1 week things have changed. So I called the doctor and the doctor said that the helper was not serving the medications correctly. So what happens is that this patient, every time she comes with the helper and the helper doesn't speak Mandarin. So when she was asked in the clinic, she claims that the patient was still on donepezil 5 milligrams. In essence, the patient was not taking donepezil at all because the patient had nausea last year after I started her on donepezil 5. So when she saw me in clinic, I just gave her the full 10 milligrams dose, and apparently she suffered side effects from it. But interestingly, what I gathered from the daughter is that this patient was served valsartan 240 milligrams on a daily basis since end of 2022. So actually we have our answers as to why, or our postulation as to why the creatinine was actually climbing so rapidly because this patient was just being overdosed with an ARB. Okay. This second case is actually an inpatient case, an autogeriatric case that I was managing. It's an 82-year-old Chinese male with a GOBI, COPD, type 2 respiratory failure, right heart failure, hypertension. So came in for a fall, had a neck or femur fracture, went for bipolar. So post-operatively went to high D because he was persistently tachycardic. So we flushed him, even when he came out from the high D after a CTPA done, didn't show any PE. He came out from high D, still persistently tachycardic. We thought, hey, maybe he's a bit septic, so we gave him antibiotics, still tachycardic. And one day when we were rounding, the pharmacist was beside us and he sort of did an informal med recon with the patient. And he went to the bedside and said, are there any other medications you're taking at home? And so the patient tells us he's actually taking Nifetex. So Nifetex was not on our NEHR. Okay, so unless you do a very, very detailed med recon, you wouldn't know what the patient is actually taking at home. So we started him back on a bit of atenolol and his tachycardia resolved. So what in essence this patient went into iatrogenic rebound tachycardia. Yeah. Okay. So that's I wanted to just highlight how important medication reconciliation is. But the next big thing which most of us physicians do is prescribing. And what we need to do would be how do we want to effect conscious prescribing. Okay, so I'm sure most of you all know about this index. It's called a medication appropriateness index. If you ask me, I think it's just too many questions to go through every time we want to prescribe some a medication for a patient. But it's just things that you probably need to think about, the important things that you need to think about when we want to prescribe something for a patient. Our patients that we deal with are not young, they're not robust. So there is no theory that there's one size fit all. How we have our research papers, our inclusion criteria about how most of our patients fit into this this age group and this set of diagnoses. But in essence, actual fact, a lot of our older adults are not included in all these trials, and they really have a whole range of frailty states. So there's really no magic number or magic dose that we give them that is assured that they will benefit totally from it lah. Yeah. So in essence, we usually think about non-pharm first. We think about the applicability of the evidence-based medicine, especially a lot of them don't include the very frail. We think about the time to benefit. So if we have a patient who's at the end of life with only a 1-year prognosis, we might really want to think about whether it's useful to prescribe aspirin for cardiovascular prevention when the time to benefit is 2 years. So it needs a lot of thought with regards to commencing medications when we talk about time to benefit. We think about side effect profile, obviously, and we think about its interaction with geriatric syndromes. And we think about the practicality of drug administration. And this is are the few medications I want to highlight when we think about practicality. These 6 medications are medications that we try and counsel as much as we can in an inpatient setting. They're quite self-explanatory. When we send a vulnerable older adult home with social frailty, for example, and he's living alone, we must really be very sure that they are able to use an insulin pen properly. They are able to take bisphosphonates properly because they need to sit upright for half an hour. They're not supposed to lie down. They cannot take bisphosphonates with food or with other medications. So there's a lot of things to think about when we prescribe. There's no point giving a medication to a patient if the patient is not going to use it properly. So I always tell my patients that if unless there's a caregiver at home, I will not prescribe bisphosphonates, especially to a demented patient who cannot take it properly, because the oral bioavailability of bisphosphonates is very, very poor. So if you take bisphosphonates with your meal, that's almost throwing money down the drain. Yeah, so it's looking at Madopa. So if you take Madopa together with your meal and you're wondering why the patient has end-dose effect, the first thing is not to increase the dose of Madopa, is to ask yourself, is the patient being served Madopa correctly and is being separated from his diet? Yeah. This is a very important bit in conscious prescribing. In the inpatient setting in EPIC, we have a CCT value at our storyboard. That means at the side of every patient's profile. And I tend to teach the juniors that you have to always look at the CCT value before you prescribe. But sometimes it's not there because the patient's weight is not there. So it's always good to have an estimated weight or get the nurses to weigh the patient. It's a very, very simple vital sign, or rather you call it a vital sign, but a very simple value that is very, very important, which is the weight. Okay, so I tend to have 2 apps on my phone, which are life-saving for me. Number 1 is a QX calculator, and number 2 is up-to-date. So for any antibiotic, any opioid I prescribe, any NOAC I prescribe, I try and look at whether I'm giving it the correct dose. So we know that bisphosphonates, even for bisphosphonates, between alendronate and risedronate, there is a totally different CCT cutoff. So risedronate you can give from below 30 onwards, CCT. But alendronate you can only give from 35 onwards based on the drug pamphlet. So these are very little nuances, but it's important to know. Yeah. And obviously, you don't want to give NSAIDs in somebody with a stage 4 CKD because you don't want to send them into AKI or a heart failure kind of situation. Then the other big part of conscious prescribing is, are we not giving our older adults the right medication? Are we not prescribing them what they need to be prescribed? Because we are afraid to do so, or other cultural problems or other practices that we're not comfortable with. So there are a lot of tools with regards to prescribing, and one of it is the START tool, which is a screening tool to alert the right treatment. So I just gave a snapshot here, but basically it goes by system. If you have time, do have a look at it. It tells you what is appropriate to give to patients and what we should actually try to give to patients. One bit is beta blockers in stable angina, in regards to mortality benefits. So under prescribing is also quite problematic. So So the prescribing, another big part of conscious prescribing is, are we dealing with a lot of prescribing cascade in the hospital as well as in the community? So what it means is that I give a medication to treat the side effect of another medication. And a very big example is, for example, okay, maybe I should go to the next slide. So this is a whole list of medications implicated in prescribing cascade. A patient comes to you for incontinence, and then you think to yourself, what are the differentials? And maybe the patient was started on donepezil recently, and it could be just that medication. So instead of giving the patient oxybutynin or tolteridine and then causing the patient to be more delirious, we might actually want to review the medication. Yeah. So this is an avenue for what we will call later as the next last stage of tackling polypharmacy, which is deprescribing. We do see chronic cough caused by AIDS. I think this is very common. We see recently I've learned that gabapentin and pregabalin can cause lower limb swelling. So we have patients who have constipation all the time, and then we think about, are we causing problems from our calcium, very high dose calcium channel blockers? And there's something that we can deprescribe. So I tend to, when a patient comes to me for constipation, I tend to look at the medication list first before giving them a whole gamut of laxatives to take. If I can deprescribe the iron, I can deprescribe the calcium, I will do that, and then probably give them laxative, of course. But if I can reduce the harm from a medication that has no obvious benefit, I will take it away. Yeah. So that's something to think about when we think about prescribing cascade. Okay, so so I thought I'll just put in this this quotation here, because as I was mentioning the first slide, William Osler will probably be right here. A medication causing the problem, and a medication related effect called iatrogenesis. So in law, we know you're always innocent unless proven guilty, but actually in any adult who comes to you, the medication is proven guilty, is guilty unless proven innocent. So one very big one is lower limb swelling. A lot of our patients come to us for lower limb swelling, and we send urine PCR, we send an echo, we give them furosemide. But actually the very, very simple thing to do is just to look at the list of medications that was prescribed in the last 1 or 2 months ago. And the patient was on amlodipine before, newly prescribed, or a high dose gabapentin. It might be worth just taking off first and seeing whether it resolves. Yeah. Okay, and the last bit is actually about deprescribing. It used to be called a geriatrician salute. I think mainly because geriatricians feel very comfortable in doing deprescribing work. So it's actually a systematic patient-centered process. These are actually 2 patients that I came across. The first patient is quite some time ago. The second patient is one of my clinic patients. When we talk about deprescribing, we really need to go through 2 questions in our mind. Is the medication that's prescribed useful? And are there already risks, or are there already side effects to the patient? Obviously, if they, the pendulum moves towards the risk more than the benefit side, then obviously you want to take it off. I think most of our community nurses who go into the community and visit the patient will understand how tough it is to pack medications that are more than 10 in number, and you were just wondering how you shove all the pills into a pill box. And it's really quite hard to take so many pills. So essentially, it's a very useful thing to try and acquire, a very useful skill to try and acquire. That is very beneficial for the patient. So this first patient is actually an inpatient that came to us for hip fracture. If you look at the list of medicines, I apologize, it's a bit small, but you can tell that the patient is on a long-acting insulin, acarbose, metformin and dimicron. So she's on 4 different medications for diabetic control alone. And you think to yourself, is there a way that this patient's medications could be simplified a bit more? If I can give you a background to this patient is seeing many private physicians, and it's also the reason why, you have many medications with no consolidation of what the patient needs. Okay, so as we all know, acarbose is it's 3 times a day dosing. It's very hard to remember. The HbA1c lowering effects is actually not very robust. So do we really need to add on 3 pills for this patient when we could, I don't know, increase the long-acting insulin a bit more of some sort? If you look down the list, the patient is on a tricyclic TCA. The patient is on, if I'm not wrong, Lomotil, Resonium every night, Stamotil, yeah, so a whole gamut of medications. This list requires at least half an hour to get through, because you need to ask the patient the indication for every single medication. And after asking the indication, you probably need to ask, is it beneficial? If the patient says no, then you might want to try and tail it off. My second patient is just, so my community nurse this patient saw me for, I can't remember, I think giddiness a couple of months ago, and you'll be shocked by the number of medications she's taking. So essentially, she has bags and bags of medications at home. I referred to the home nurse, and she did a very good job in just pulling out all the drawers and taking all the bags of medicines, and she gave me a whole list that she's taking. So this patient is also doctor hopping. She goes from one GP to the other, and she's prescribed all these medications. I mean, you have dual opioids on the list, and you're wondering why. She has multiple giddiness medicine. She's on a TCA. She's on pre-gap. So we just started deprescribing some of these. So again, there are tools for deprescribing. You have a stop tool. It's called the screening tool of older people potentially inappropriate prescriptions. It's categorized in systems, and it highlights drugs which may be inappropriate. It was found to be a better predictor of adverse events than beers. If you like to look at beers, it's also available on the internet. So I mean, this is just a snapshot for cardiovascular medications, but essentially there are friendlier antihypertensives to use rather than a thiazide diuretic or loop diuretic. And digoxin, usually we try to be very careful because they can go into digoxin toxicity if your eGFR is less than 30. Okay, so in recent times, we have a Finnish deprescribing tool called StopFall. It's actually by an expert panel. So again, I apologize, it's very small, but you can go and read the paper. They still have an expert panel, and they go through many consensus rounds, and they identify benzos and antipsychotropics as high risk of falls drugs. So you might want to be very cognizant about giving some of these drugs to the patients who are falling. So what they call it, the FRITZ drugs. So false risk increasing drugs. So again, this was pulled out from the paper. Even within each class, different medications within each class can have different potential for harm. So if you look at antidepressants, the tricyclic antidepressants are the worst. They are the most false risk increasing drugs compared to everything else. In opioids, obviously the strong ones are worse than the weak ones. You have oral hypoglycemics, for which glipizide and sulfonylureas are probably more at risk for hypoglycemia than your linagliptin or your SGLT2 inhibitors. Okay. Yeah, so when we talk about falls, I thought I'd just throw this in. I mean, walking itself is really requires a combination of 3 very robust support systems. And with aging, there is increased delay in the sensory signaling to the muscle and slower reaction times. So when you throw these patients false risk increasing drugs, what happens is that you harm one of the system, and you reduce their response time. And so when they trip over something, they have a slower reaction time, and so increased risk of fall. So when we talk about system, we talk about the vestibular system, the visual system, sensory system. You need to have a good cardiovascular system, musculoskeletal system, and the cortical functioning. So walking is really a very, it's what they call risky business. And as they grow older, it gets even riskier. Yeah. The next tool that I wanted to talk about is really the stop frail tool. This is for patients at the end of life. So if you want a guide to how you want to deprescribe medications in patients who are going to not live in the next 1 year, you might want to use this as a criteria. So obviously patients with 1 year survival prognosis, end stage heart, liver, lung, irreversible pathology, very severe dementia, bed-bound, chair-bound patients, and when symptom control is our priority rather than prevention of disease progression, okay, then you might want to look at deprescribing. So again, this is pulled out from the tool. It tells you by systems as what do we think is not very useful at the end of life. If you have a patient with a long-term catheter, it's questionable with regards to the benefit of a alpha blocker or a 5-alpha reductase inhibitor, and you might want to take it off. We talk about memantine in frail, very severe dementia and starting them. I think we probably want to think about taking it off as well. Cholesterol medications, I think most would understand why, because the time to benefit is really in years. And so forth. Yeah. Okay. So this I put in 3 big categories of drugs that the geriatrician just are very careful about, and these are the psychotropics. So but we are guilty of prescribing them also, unfortunately. So but we tend not to like to give the benzodiazepine drugs unless they are for restless leg syndrome. So I have patients who I give clonazepam for restless leg syndromes. Antipsychotics itself, even within the class of medications, they are all at risk of causing EPSC with time. I have a patient I gave risperidone to because the PTSD was just through the roof, and the patient responded very well to risperidone, but the ambulation just declined over the year, and she had a hip fracture at the end of the year from a fall. So a lot of these medications are detrimental. But if you look at number needed to harm, quetiapine is probably the best compared to the rest. Postural hypotension can also potentially be caused by antipsychotics. When we talk about antidepressants, again, what we worry about is the anticholinergic effects. The TCAs have a very high anticholinergic load, and that can cause delirium and worsening dementia. So how do we deprescribe some of these drugs? So I use the Canadian deprescribing network. There are actually many deprescribing networks around on the internet, but this is something that I usually use in the slides. So basically, when we give a benzo to a patient, we really need to be very clear of our diagnosis. Is the benzo for a sleeping disorder or a panic attack of some sort or an alcohol withdrawal? Then yes, it's clinically indicated. It's not usually given for primary insomnia. I mean, most insomnia has a secondary cause, and so we treat the secondary cause. But if not, then it really is trying to wean it off. So we tend to wean it over several weeks, and we watch for rebound symptoms. So the big thing about deprescribing is that we do not just stop a patient's medications and walk away. So we wean it down, and then we monitor them. We bring them back to clinic and make sure they're not having a rebound, because if they do rebound, they might just represent to emergency department of some sort. Yeah. And then the other big drug is anticholinergics. We absolutely do not like them. So so the sedative antihistamines are usually our first gen antihistamines, the atarax, the pyridons. I had one patient who came in to us who was very frail elderly, who was on pyridon like on almost a daily basis, and it's just not indicated. So you just wonder why she's on a very strong sedative for so long. Yeah. So anti-muscarinics are also a problem. NRX we do not like. Some of the other ones I've talked about, which is the TCA. So if you have a patient come with you for example, urinary retention, and you think, oh, is this a prostate problem, or is this constipation? It's actually good practice to just see whether it's the medication that's causing it. Okay, so I repeat this slide a lot, but it's called the anticholinergic burden scale, and it predicts impairment in cognitive and physical functioning, and it goes by a 3-point scale. So at the end of that spectrum, which is a 3-point, those that have very high anticholinergic burden. So between nortriptyline and nortriptyline is a bit better in terms of the anticholinergic profile. And yeah, so basically we try not to prescribe anything in the 3-point load lah. Yeah. And the last one, which is very, very common, we give them a lot to our patients, but we watch antihypertensives like a hawk in our clinics, because we know that sometimes it can cause very, very detrimental postural hypotension. So it's, I mean, these are all self-explanatory, but apparently all the antihypertensives can cause some form of postural problems. Okay, so I think we're finishing soon. I just want to highlight a very, very neglected vital sign when we talk about antihypertensives. If you look at the study chart on the right, patients with postural hypotension has increased risk of falls and fractures. As you go, the one in red are patients with postural hypotension. So they increased risk of hospitalization, syncopes, falls, fractures. It's a very, very common medical condition, but we don't check it enough. And I cannot emphasize how important it is. A lot of our community nurses go out and they do check postural hypertension very, very, very diligently, but I think we don't do it very much in our clinics, and it's actually a very important problem that we see. Yeah. So it needs to be assessed and monitored for every older adult on medications at risk for postural hypertension, especially if the patient is frail. Okay, so what is postural or orthostatic hypotension as defined by the American Academy of Neurology? It's basically just a systolic drop of 20 or diastolic drop of 10. So a lot of times we are taught that we need to do it from a supine to standing. That's correct. We need to do it from supine to standing. So no supine to sitting. It's just supine to standing. But we may be able to cut the time from a 3-minute standing time to a 1-minute standing time. So this study that was passed to me from my con as I was a registrar still stays with me. It tells you in this study, it shows how predictive even a postural BP checked at 1 minute is with regards to adverse outcomes. Yeah. So if you have no time in clinic or no time in the patient's home, you can 1 minute, even 15 seconds, I think in this study, 50 seconds to 1 minute is sufficient to predict giddiness and adverse outcomes. Okay, so unfortunately, a lot of times in medicine, we don't have textbook presentations, and they don't tell you all the time that they are giddy, but actually they do have postural hypotension. So if they come to clinic and we start them on antihypertensive and ask them, are you giddy on standing? And they said no. It doesn't mean that they don't have postural hypotension. So I tend to take it with a pinch of salt. So if they tell me they have no giddiness, oh yay, one checklist down, but I would still need to check them objectively if they have postural hypertension. So I mean, textbook symptoms like giddiness, I was saying, may not come in, but some patients get lower limb weakness when they stand up. They will tell you that they have a bit of a sway. Apparently one of my colleagues actually had a patient who had dyspnea when she stood up. So some of these symptoms might present as postural hypotension. I have one patient who has coat hanger pain, which is very classic textbook neck and shoulder pain. So he has autonomic postural hypotension. So when he stands up, his BP drops to 60. And he can tell you very definitely when he stands up, there's this ache around his neck. So I send him for x-rays and things like that, but it's just spondylosis. But when he sits down, it's completely resolved, or when he lies down. So it's very classic coat hanger pain. And if you look at the chart on the right, actually, if on the far right, if you look at the SBP fall of 20 to 40, the red bar is asymptomatic, and actually a large proportion of them are asymptomatic, especially in autonomic neuropathies. One of the very common etiologies is long-standing diabetes. So if you start a frail elderly adult with very long-standing type 2 diabetes on an antihypertensive, you need to be very, very careful in terms of whether you're causing postural hypertension, because they may, in actual fact, already have autonomic DM-related neuropathies. Okay, so sorry, just the last few slides. So this is just how we want to deprescribe in frail diabetic patients. A lot of times when we go to subspecialty clinic, most people are very goal-driven. So I need to achieve an LDL of less than 1.8 in patients with heart disease. I need to achieve a HbA1c of less than 7% in patients with diabetes. You know, I need to start the 4 drugs in patients with systolic heart failure. But we cannot be how do I say, we have to look at it, as I was saying in the first stage, a very broad overview of the patient, because if you want to achieve that goal, you might run into problems. And it is a problem in frail older adults. If you want to achieve a goal of less than 7% in a chair-bound, demented patient who is at a high risk of poor oral intake or fluctuating oral intake, as well as mentioned, unstable disability, we run into problems of hypoglycemia. So this is a ADA standard of medical care in diabetes in 2022. This is just recently revised. The one in 2017 apparently had a HbA1c target of 7, 8, and 8.5. But now, even for the very, very complex frail ones, they're just took away the HbA1c completely. So this is a revised criteria. They said, maybe we shouldn't rely on HbA1c too much. You know, if fasting glucose is okay, the patient doesn't have symptoms of hypoglycemia, symptomatic hyperglycemia, then it should be fine. So it's really just rethinking some of these goals. Okay, so as I was mentioning, when we talk about deprescribing, a lot of our very frail, vulnerable, demented patients in the nursing homes are dealing with a lot of poor nutrition. They don't want to eat. They put their food in their mouth. They start spitting it out, and then we start referring dietitian, ST. But actually, a big part is, as I'm saying, the elephant in the room again, is actually the medication list. If we can take off some of these medications, then we might be able to do away with that. Maybe a few patients who's going to benefit from it. We will never know, but it's how much we can do as there are. That the medications are there with no clear benefit. There's no reason why the patient should be, number one, paying for it, and number two, suffering from its side effects. Yeah, so there's a whole list. It's very small here, but there's really many medications that can cause poor nutrition. So yeah, I'm at the end of my talk. I just want to put in 6 very big points that maybe you want to take home with. When we talk about geriatric care, it's really a whole heterogeneous population of patients with varying frailty states. I mean, you could have a 90-year-old who's driving, hopefully not banking anybody, but a 90-year-old who's driving, and a 65-year-old with young onset dementia, and who's just bedbound. So it really is a whole range of frailty states and complexity of care. I think those colleagues in nursing homes, you probably see this range of frailty states, and it's very hard to care for, think about all these aspects of care. Fragmentation of care is a very, very big problem, not only in America, it's everywhere. And we have to centralize ownership of care to try and improve care of our patients, and not only just polypharmacy. we want to have a patients know that if they go and see their whoever primary person who's looking after them, could be a geriatrician, it could be a GP, they have to they take ownership for their care. So for example, if a subspecialty gives drugs which we deem is inappropriate, then we might want to talk to them and decide, have a discussion about whether this is really benefiting the patient. Because if you have seen the patient for some time, it's actually, you will understand how the patient's trajectory goes. So ownership of care, I think, is very important. I think the healthy ASG is quite useful with regards to that. The fourth point is that prescribing in an older adult is actually very challenging. No one size fit all, as I was saying. Medication review and recon should be ideally part of any clinical encounter, but we are cognizant that it takes time, and in the community, sometimes time is the problem, and resources are the constraint. But if you do have enough bandwidth, it's very important to look at it. And maybe it shouldn't just, deprescribing shouldn't just be a geriatrician salute, it should be a physician salute. So anyone who is comfortable and it feels that it's in the best interest of the patient should recognize it and try and deprescribe as much as possible. Yeah. So yeah, thank you for listening. I hope I haven't lost anybody, but yeah. So that's all at the end of my talk. Yeah.
Thank you, Jasmine.
Yes.
And there are a lot of questions here. Some
Yeah.
of them are related to practice and some of them are clinical. Maybe perhaps let me just ask the clinical questions first, and then maybe you leave the practice issues to the final points. So you mentioned about the Cockcroft-Gott CCT as a kind of vital signs on your EMR system, and then there's this EGFR. Somebody mentioned that in his experience they are quite different. So when do you use the Cockcroft-Gott equation for creatinine clearance, and when do you use estimated GFR? Yeah. Yeah.
Okay, so we use Cockcroft-Gott most of the time.
Yeah.
If you look at most of the drug pamphlets, they do use Cockcroft-Gott. I think metformin uses EGFR.
Yeah.
But even in prescribing in our older adults, I tend to like to use Cockcroft-Gott as well in metformin use. Because as we know, creatinine is obviously a very poor marker of renal function in a very skinny lady or a very cachectic older adult. So in essence, if you ask most physicians in the inpatient setting, we use creatinine clearance most of the time. If the patient's creatinine clearance falls to very low 30s and the EGFR seems to be okay, I tend to still not want to use metformin very much. Or rather, I cut down the dose a bit more. There was a recent conference that talked about metformin and frailty. This endocrinologist actually try and put forth the idea that as the patient gets more frail, you might want to think about metformin use a bit more, especially when they're not eating very much anymore. That's metformin, but in essence, we do use creatinine clearance very much, Cockcroft-Gott. Some papers have said that it overestimates it sometimes. Yeah, but that seems to be what we generally use, even in our inpatient storyboard when we check.
So generally, the Cockcroft-Gott is more accurate.
Yeah.
Okay. Yeah. And so the next question is relating to deprescribing donepezil and memantine. Do we need to taper off, or can we just stop?
I tend to taper off.
Okay.
Okay. I think that most of us would taper off rather than take it off completely. What I tell my patients is that the apathy might increase. So sometimes when we take off the memantine or we take off the donepezil, they tend to be a bit more obtunded, not so engaged. And that's when you know they have probably withdrawing from the cessation of donepezil. Or if you see that the patient's behavior starts getting worse. So when we write our prescription down, or rather some of us practice in our notes, we will put there donepezil for behavioral control. So that will give you a clear indication of why the physician started the donepezil in the first place. And if you take it off, then you would have to counsel the family of on some of the rebound symptoms that they might experience. So if they get more behavioral issues at home, you might say, you need to call me back, or you need to come back and, so that or the patient should continue on it. Most of the time we take off, or rather I take off donepezil because the patients just stop eating. Donepezil can cause loss of appetite, loss of weight, nausea, vomiting. Although sometimes we change the dosing time to a night dose, which tends to help sometimes, but they still continue to lose weight, and then we just take it off and switch to something else. Yeah.
Thanks.
Yeah.
You mentioned about the autonomic neuropathy tend to cause asymptomatic postural hypotension. So the question here is, do we need to be concerned about asymptomatic postural hypotension?
Yeah, it's a big, we do see it a lot of times in the inpatient setting. Asymptomatic postural hypertension is actually quite common.
And it's a fall risk, even though it doesn't cause
it's a fall risk, yes.
Okay.
And when you talk about a history taking, so it's always history first, right? But we oftentimes don't have a very good history. So the patient cannot tell you that, they are giddy, but you can observe them when you stand up and they have a sway, then you might think to yourself, is this postural related? Yeah.
Okay.
Or if they sit down at lunch and the helper tells you that actually once he tends to doze off after lunch, then you might want to be cognizant to see, you might want to get them to check, the BP and make sure that it's not too low. Yeah.
So in a way, they are just not having the typical giddiness symptoms, but they have other atypical symptoms of postural hypertension.
Yeah.
Like
So the
pain
atypical presentation. Yeah.
Yes. Yeah, thanks. Then there's a question about prescribing Madopa for persons with advanced Parkinson's disease who is fully bedbound, fully dependent. Perhaps he's still swallowing. Do we still continue with Madopa for the sake of the swallowing? Does it help?
Okay. This one, I don't think we have very conclusive evidence.
Yeah.
I know a colleague who will take it off completely and not worry about dysphagia, but I think some of us do worry about dysphagia. And especially if a patient is chair-bound, I feel that it does help a bit with the transfers.
Yes.
In some patients who are very, very stiff. So sometimes I when they are on high dose Madopa and they are bedbound, we do try to deprescribe, but usually at the dose where they don't have side effects from the Madopa itself. For example, instead of prescribing midodrine to a patient, I want to cut down the Madopa first, especially if the patient is bedbound. So at least they can get to sit or chair-bound, so at least they get to sit out a bit more.
Yes.
So yes, we do prescribe as they get a bit frailer and a bit bound, but then we need to again tell families about what to expect.
So in a way, titrate against symptoms. Like if you stop the Madopa and the dysphagia gets worse, then maybe Madopa was working, was actually effective.
Yeah.
Then, so now there are some other questions like multivitamins. Is it helpful for people who are malnourished? Do you think multivitamins?
Okay, I know I don't really prescribe multivitamins. I'm not too sure about the evidence of how, in terms of mortality prevention or, mortality benefit, or I don't think there is much evidence for mortality benefit or any of the syndromes, including dementia. So I don't usually, it just, to me, it's pure burden. So if they can actually get a dietitian to get them to include high caloric intake in their food, then rather natural means probably much better.
And also assess
supplementation.
what's the cause of the poor appetite, right?
Yeah.
So maybe last two questions related to practice. So as a specialist, I'm sure you co-manage with many specialists and subspecialists, super specialists. So how do you deal with polypharmacy due to that? The first question asked is, can the pharmacists do something? But I'm sure pharmacists also, they have to, they have certain restriction in what they can do. But as a doctor like yourself, how do you deprescribe in the midst of multi-specialists taking care of a patient?
Okay. So it's so I think number one is, as I was saying, a very big part is taking ownership for the care.
Yes.
So you need to be saying that this is something I want to do for the patient. If anything happens, I would have to. It's me who counsel the patient. I will sort out any of the repercussions of which. So that ownership is very important. then number two is how do we communicate that to the relevant subspecialty? So a lot of times we do either a phone call follow-up, a phone call communication of some sort, or a memo of some sort. For medications that I'm not too familiar with, I tend to hold a discussion with the relevant subspecialties. But we at geriatricians, we do deprescribe if we feel that the patient is not going to benefit from the medication. And sometimes it's just really not having the knowledge about frailty and about how the side effects of how the drug disease interaction. Sometimes it's just not knowing. And so sometimes when you talk to the subspecialty care, they're actually quite open to hearing you out.
It might be easier for you working in the hospital, but for us in the community, it takes a lot of time, to hunt down each one of them.
Yes, it takes a lot of time.
So sometimes what I do is I really believe that this is overprescribing. I will remove it. But then again, I'm not sure whether I'm stepping on anyone's toes. But it's very difficult, to call everyone up and discuss about their prescribing.
Yes.
Then there's one question about cheap drugs versus expensive drugs in care for people with diabetes. So people living in the community, do you have any opinion about the cost of prescriptions, like patients with diabetes? Some prescriptions that are very efficacious and very beneficial are actually quite expensive. It's not exactly related to polypharmacy, but it does relate with medication management as a whole, I suppose.
As in the question is whether we consider costs as one of them. Okay.
Like how do a doctor reconcile the cost of prescribing older versus newer medications? Like sometimes you believe that the newer medicines, which is more expensive, is really beneficial to the frail elders. Then costs come in the way. Well, I suppose you just have to do your equation. I mean, cost versus benefit now.
I think it's tough.
Yeah,
it's quite tough. I mean, if you just look at the class of medicines in dementia prescribing, you have a ribastine patch, which is known to cause slightly less GI side effects and better studied in patients with Lewy body dementia.
Yes.
And then you have donepezil, which is so much cheaper.
Yes.
So but ribastine is so easy to give. They don't need to take pills. So some of the patients get subsidy. So we try and apply subsidy for them in patients in the hospital setting. But most of them are okay to go ahead with it. But subsidy is one way to go. We try and get funding if we can. But it is tough. I mean, some of the medications are very clearly beneficial, but it's just not as cost effective. I mean, not as cost conscious when we think about it. I mean, it's part of the MAI questions, the medication appropriateness index, when we talk about prescribing, and cost is one of it. So I'm not sure in the community if you guys get subsidies as well for.
Well, we do our best to get subsidies. I mean, in HNF, we do get subsidized medicine from the polyclinics. And if necessary, our social workers will apply for some kind of subsidies for them. But still, cost is always an issue. I mean, the world is like that. We cannot. We're not living in Disneyland. I'd like to take the last question from Dr. Talk because it's quite heartfelt. It's related to the frustration. It's very difficult to deprescribe medications for end-stage kidney and heart failure. It seems like almost all the medicines are necessary. And the patients are miserable, and yet it's end stage. I suppose the prognosis is quite poor. But what are your principles in deprescribing for people with end stage organ failure?
I think when we talk about end stage organ failure, we talk about even within the end stage organ failure itself, there's different stages. Is this patient actually dying? Obviously, if we're at one spectrum, actually, if they're on palliative care follow-up and they are on fentanyl already, and then we take off the Recamon, we take off the iron, we take off the renal vitamin, there's no need for any of these medications.
Yeah.
What matters most is symptom control, and so diuretics are usually on.
Yeah.
What matters most is if the patient has tachycardia or AF-driven heart failure, and we obviously tachycardia is very uncomfortable at the end of life, and so we keep the bisoprolol on. So it's really moving towards symptom control, and if we feel that the medications do help with symptom control, then yes, we keep it on.
Would you keep NOAC on the apixaban and the rivaroxaban? You mentioned about AF in end-stage kidney or end-stage heart failure.
Yeah, we don't take it off.
You take it off, okay.
Yes, so we do, especially if they're dying, but we do have some end-stage heart failure patients who are still, hanging around and still eating and still having conversations. Then
we want to prevent stroke, yeah.
Yeah, so those patients, we do sometimes put it on, but it is a very difficult thing to try and reconcile with. It's not easy, yeah.
Because so in a way, prioritize, right? End of life is for quality of life and symptom management. Yeah. So you see which are the medicines that's towards this goal, huh?
Yes. Yeah. Because in essence, organ failure is very hard to prognosticate.
Yes.
It's not like cancer, so it tends to be more difficult now. Yeah.
Okay, maybe there's one final question, because this gentleman really wish you could give more details. How do you tail off donepezil and memantine?
Okay. If the patient is on 10 milligrams of donepezil, you could go down to 5. And
for 1 month? For
sorry?
1 week? For how long? Then you take it off?
It depends on when you see them. So most of the time I deprescribe, and then if they don't want to come back to see me, then I'll tell them over the next 1-2 weeks, if there's no rebound symptoms, they can just take it off.
Yeah.
But if they come back to see me in 3 months, 3 to 4 months, I usually get them to tail down to 5, and then we see how they go when they come back.
Okay. Yes.
That's the same for memantine. Go down from 10 to 5 or 5 to nothing. Yeah. I mean, if you want to do it more graded, it's also fine. If you go from 10 to 2.5, 10 to 5, 5 to 2.5, that's fine. Some of my colleagues start at 2.5, but yeah, it's physician dependent, but it's more that slow titration. It's the same with benzodiazepines. So you just cut it slowly.
Okay. So thank you very much, Jasmine. It's been a wonderful afternoon and learned a lot from you. And thanks for taking all the questions. And I'd like to thank the audience as well for spending your afternoon with us. So I hope you get our CME points. Christina, would you like to say something?
All right, except see you all next month, and Happy New Year.
Yeah.
Thanks,
next
Jasmine.
month we're going to talk about nutrition for frailty. Yeah, okay. We'll send out the EDM soon. Okay. Bye-bye.
Bye-bye.
Thanks,
Thank
Jasmine.
you.
Bye-bye.
Thank you. Bye.
Bye-bye.
Happy weekend.